Monica Wesbury, and I'm going to talk about my change project for this semester. This semester has given me an opportunity to provide a change within my facility. The change that I've decided to do was early and frequent patient ambulation within the ICU for medically stable patients. This semester has given me an opportunity not only to learn more information about patient ambulation, but also how to meet with department heads, managers, administration, how to overcome goals, how to overcome obstacles, achieve goals, and talk to administration about change. The goal of this project was to decrease deconditioning and complications of patients within the ICU by early and frequent patient ambulation in medically stable ICU patients. The objective is to have a 10-minute in-service with ICU staff to educate them about early and frequent patient ambulation, and to pilot a program for development system-wide within ICUs for medically stable patients. As in all projects, this project, I had to identify the problem. The problem that we had with restraining forces were nurse unwillingness to ambulate their patients and resistance to change. The nurse problem was more laziness than anything that I had found. A few nurses decided that this was physical therapy's job and not a nursing job, even though it's within our scope, and it is expected of nurses to ambulate their patients. Driving forces that I had within my project were Dr. Waslick, our highest admitting physician, and Dr. Rajan, the director of the ICU, were both on my side for this. Also, there's overwhelming amounts of literature stating how frequent and early patient ambulation leads to decreased length of stay within the hospital. This ultimately saves the hospital money and the patient. Because when patients are when they're in the hospital longer than medically necessary, their insurance stops reimbursing the facility. This project took place at Beckley Appalachian Regional Hospital within the ICU. It was approved by administration and the department manager. We have 13 hospitals within West Virginia and Kentucky. We're a non-for-profit, 173-bed acute care facility, which includes 60 psychiatric beds. Within our facility in Beckley, we have an emergency room, a cardiac cath lab, an intensive care unit, a step-down progressive care unit, a psychiatric facility, and an operating room. Within our facility, the director of nursing is Angela Rivera, and the department manager of ICU is Brad Walls. For my needs assessment, I had a survey that I passed out to my staff, which was actually me giving it to my staff and standing very close to them until they answered all the questions. Because as we all know, it's very difficult for a nurse to find 5 minutes within their day to complete an assessment and then give it back. We might complete it, but sometimes we leave it where we sit and it gets lost. Some questions I asked my staff were, do you feel like patients need more ambulation? Of the 16 surveys that I received back, all 16 said yes, that our patients need more ambulation. I also asked, is getting a patient up to a chair unreasonable to ask a nurse to do? 7 people responded no, but there were several feedbacks saying that, I received several feedback surveys that said that they had some questions about time management. My action plan was to develop a committee, meet with them, decide what criteria to use to assess patients. We also consulted the director of physical therapy at the University of Maryland. Her name was Chris Wells, and the only thing she didn't like about the plan that I had developed with my committee was we didn't have any signage for our doors. So throughout the committee meetings, we developed a signage, which we'll see in a few slides. The benefits of ambulation that the literature proved continually, no matter what article I read, is that getting patients out of bed has shown to decrease length of stay within the hospital, that ambulation prevents deconditioning of patients, early ambulation can help our patients be discharged home instead of to a rehab facility, which can make a big difference in our local population because we have more grandparents taking care of children now than we have in previous generations, which is so important both for the grandparent who's responsible for the child and the child who's dependent upon the grandparent to get to school, sporting events, their job. It's important overall that our patients are able to be discharged home. Ambulatory aids that we have within our ICU are ceiling lifts over our beds, 4-point canes, walkers, and draw sheets. And all of this is an example of each that we have. The signage that we decided to use as a committee were a stoplight, with a red light being a patient total assist where they're unable to bear weight on one or both legs. A yellow light is that you need to use an assistive device or a more than one person assist. And a green light is the patient is independent with no ambulatory assistance required. Although the nurse may need to be at the bedside to unhook the cardiac monitor and the IV, the patient's able to ambulate on their own. Things that worked well for us were the staff was able to quickly learn the assessment tool and the signage. Another thing that worked well was that no new skill was required for this. Within nursing school, nurses are taught how to ambulate patients. It's in one of the first semesters of skills labs, is getting a patient out of bed. The committee meetings were easy to get together, and if some staff were unable to attend, they were easily able to be contacted to update on what the committee had talked about. Other things that work for my plan is that we have a routine sheet that we use for a report sheet that everybody has. And on this report sheet, it actually lists the patient's activity level. So it was easy for our staff to remember to say they're a yellow light, they're a red light while they're in report, because it's already on a report sheet. Things that worked against us were that some staff didn't want to ambulate their patient, regardless of the education or encouragement provided. Another thing that worked against us was that some patients did not ambulate well at home, and they didn't have their personal ambulation tool, so they felt very uncomfortable ambulating with our staff, as though we would let them fall. For my in-service, there was an in-service held on both shifts at 6:30 in the morning and 6:30 in the evening. Snacks were provided for both shifts. The signage was shown to the staff, and they agreed and easily understood the signage. They were explained the exclusion criteria, given examples, and were mostly understanding of the examples. And they were educated that our go live was April 16th. On go live, the patient census was 10. 4 patients were able to meet the criteria. They did not meet the exclusion criteria, and they were able to be out of bed, and 3 of those patients were ambulated. The clinical nurse manager and the change agent were both available for ambulation that day. Only 3 things happen naturally in organizations: friction, confusion, and underperformance. Everything else requires leadership. My name is Nicole Asbury again. Thank you so much for this opportunity to allow me to make a change within my facility for the greater good of our patients.